Hi, I'm Adrienne. I'm a women's health nurse practitioner, and let's talk about IUD pain management. This was released from Contemporary OBGYN, and I went through it, I highlighted all the good stuff, so then we can talk about it and talk about the best ways to make IUD insertions much more comfortable. So this is a really common concern for a lot of patients. It's a big barrier to actually getting an IUD. I have patients all the time who are like, I would get one, but I've seen too many horror stories, or the big reason I'm not getting one is due to pain management. So if you have not even thought about IUDs, one of the big reasons that people want to utilize them is due to their effectiveness. The progesterone IUDs have a 0.2% failure rate. Amazing. And the Paragard or the copper IUD has a 0.6% failure rate, and an actual tubal ligation or tubal sterilization procedure has a 0.5% failure rate. So they are incredibly effective options for people, and long-term and reversible. So they're a great option, but the barrier again is pain management. So let's talk about it. So oral medication. I prescribe ibuprofen for patients all the time. NSAIDs are very typical to give patients prior to an IUD insertion. You say, okay, here's your 600 milligram tablet of ibuprofen. They'll be prescribed before, or they have it there for you at the facility to take prior to your procedure. But in randomized trials, it hasn't been associated with less IUD insertion pain. So what has been associated with more pain control is a medication called ketorolac or Toradol. So this is like a bigger strength of an NSAID. It's still in the NSAID family. So if you have an allergy to NSAIDs, then or an intolerance or a contraindication, you still can't use it. But I have had patients where they've reported like, hey, like, no, I've had a terrible experience with IUD insertions before. It was terrible last time. And I have talked to them about Toradol. We typically give a smaller amount. And we always have you take it again, like the ibuprofen, about an hour before. But typically clinics don't just keep it in stock. So it wouldn't be something like if you're going in for your IUD insertion that day, like, hey, do you have ketorolac here that I could take? Typically it's something you're going to talk to your provider about before you actually have the insertion done. Now, often we don't use naproxen, but in a study here, they did say that outcomes did show that naproxen, using it after the IUD insertion, did help with pain management after. So if you're someone who's like, naproxen works better for me, okay, yeah, that's something to talk to your provider about and potentially use that, especially for cramping and pain after the insertion. What about local analgesia or local pain treatment? So there's a couple different ways that they talk about in this article. There are some that like I personally have never used or haven't really seen done very often, but they're good to know about, and always something that we can consider to improve our own practice. So there is self-administered gels, but compared with placebo, vaginal gels did not appear to have an impact on the pain associated with IUD insertion. So if you're like, okay, I've heard about these lidocaine gels, maybe I can use lidocaine internally and that'll help. Okay, it looks like the self-administered ones have not been proven to actually be that effective. But they did talk about an oil and water formulation with lidocaine and prilocaine together, which I've actually never prescribed that. I've never like had it in stock somewhere, but it's interesting and it's something I can look into now. But they showed promising data as a pain relief strategy in a randomized control trial comparing that lidocaine and prilocaine cream together with the misoprostol or the placebo. But it's also like you're using two things versus a placebo. So knowing that that's an option might be something I look into, but it's also comparing to injectable lidocaine. So if we inject lidocaine or what we would call a paracervical block, that absolutely has lessened pain association with various steps of the IUD insertion. So while we place the tenaculum, which is the thing we use to grasp onto the cervix, as we measure the uterus, as we put the IUD in, after, so using lidocaine which is most of the time pretty easy to get, easy to inject, easy-ish to have in stock. Might be, from my perspective, easier than some cream gel I've never heard of. And the cream gel stuff you have to insert like 5 minutes before and then wait. So it does increase your time of your appointment too. So lidocaine is awesome. 10 out of 10 recommend. Yes, it is a shot. And I've had patients who said, you know what, that scares me. A shot is going where? But most patients do report that it's very helpful, just like from an anecdotal perspective. Most patients report that it's very helpful. It's just getting over that like mental block of, oh my gosh, there's a needle going into my cervix. So I understand, obviously that can be scary too. But in both studies that they look at here, for the IUD insertion, the pain score was lower for women given the cervical block than for those given no block. So it can be really helpful if you can get your brain past the needle part. Cervical priming agents or cervical ripening agents, whatever you like to call them. Ripe cervix is a super weird way to talk about it, but it's also a medication called misoprostol. And it has demonstrated efficacy in reducing pain associated with IUD insertions. But they have they're like, oh, there's mixed reviews. They said it can definitely help if you've had a failed insertion before, like they tried once and they couldn't get it in. There is, it has been demonstrated that misoprostol can be helpful for that second try. I will say this is like one part where I disagreed with. They're like, it's not clinically significant efficacy in reducing pain, but I've had a lot of patients where, if you can tolerate misoprostol either inserted vaginally or taken orally, it helps a lot. So that's one disagreement I have just from like an anecdotal perspective. Last medication one they talked about was nitrous oxide. So this is one I've actually asked a few people about who I know work in women's health. Hey, are you using this? I'm seeing more people use it. The barriers for us is that, a patient has to be comfortable putting the mask on themselves. Some people feel very out of control with medications like that, and they want to be in control of the situation. Stocking the actual nitrous and the tubing and the mask, and then there's always the fear too that if someone knows that you have nitrous in your office, then you could run the risk of someone breaking into your office to steal it. So there are some barriers to providers keeping it stocked. I know it's not incredibly expensive, but it could be a safety issue for some providers. So that's, it's liability. That's why some people don't want to deal with it. But patients in these studies did demonstrate a lower pain experience and a greater patient satisfaction when they were using the nitrous. But it's funny, then they had a different study that showed it didn't indicate pain reduction at all in the scores after using nitrous, but the patients still reported better satisfaction with their pain management. So it's like, okay, maybe you're saying my pain wasn't that much less than I thought it would be. My pain was still present, but I really appreciate the things that were put in place. Who knows? So it's conflicting studies on nitrous. I don't see a lot of offices in my area doing it. I don't think we're going to do it anytime soon, but I would love to hear if you've ever used it for any procedures and it worked for you, or vice versa, or it didn't work for you. Who knows? Then the non-pharmacologic management, which some of these are really funny. Verbal analgesia is one of them, which is if your clinician speaks in a low, calming voice, which is kind of hilarious, but I try and do that anyway, but I don't think of it as verbal analgesia. Atraumatic forceps, so there's different types of forceps, so it's this kind of terrifying looking torture device that we used to grab onto the cervix, but it showed that the different types of forceps didn't actually reduce pain. But that's what the lidocaine is there for, to go at the tenaculum site so that it reduces pain that way. So you could ask hey, what type of forceps do you have? But or what type of forceps do you have? But it might not change your pain. So not a big deal, but that's helpful. It's oh, you don't have the right forceps, I'm going to have so much pain. No, you're not. It's going to be the same. Timing with the menstrual cycle. So we used to tell people oh my gosh, to make your life easier, you should do your IUD insertion on your period. Some ways that can be helpful is number one, we know you're not pregnant. Love it. Your cervix is already a little bit open, you're already bleeding, you're already having some cramping, so sometimes all of that blends together and then you only have to deal with it once. It's not like, oh, you had your period, then 2 weeks later you had to deal with the cramping and pain of an IUD insertion. So from that perspective, it kind of makes sense. But the World Health Organization looked at it and said the pain perception at the time of the insertion and bleeding pattern and satisfaction at 3 months didn't change if a patient had it inserted during or after their cycle. So go whenever it works for you. And the Paragard copper IUD can be used as emergency contraception, so we can't wait around for your cycle. We have to do it when we need to do it. So I hope that was helpful. It was an interesting article that, kind of be helpful from my perspective of like justifying what we do and saying, okay, should we look at other options? But I hope that was helpful. Love to hear your comments. And then let me know if there's anything else you want to talk about.